What is rehab or rehabilitation? My name is Fred Begaris, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. I recently had a patient that was very frustrated. They recently had an episode of severe neck/shoulder blade pain, and that can be very debilitating. They were relatively new to the country, and this was their first encounter with the healthcare system in the United States. They were here on a work visa, but otherwise a young, healthy person who just simply needed care. They ended up seeing an orthopedic surgeon for this periscapular pain. I reviewed the notes prior to the visit, and it seemed like they had a pretty decent differential diagnosis. They ended up ordering an MRI of the chest. I'm not exactly sure what they were looking for, but the MRI did come back normal. They were referred to physical therapy, but they opted not to go. So essentially, I was a second opinion. During my discussion, I shared my differential, but the main takeaway was that the patient was incredibly frustrated. Navigating the U.S. healthcare system can be frustrating for many reasons, and in this particular case, I think the patient was most upset by the lack of a specific diagnosis for their pain. The patient's healthcare experience had been different before this, and maybe it's apples to oranges. Neck and periscapular pain are often clinical diagnoses rather than something that shows up on a radiographic image or lab. Many musculoskeletal and spine-related conditions present with fairly normal findings and are diagnosed based on clinical evidence. That's likely the more definitive way these diagnoses are made, sometimes with or without injections for confirmation. However, this kind of frustration is fairly common among patients and certainly in my clinic. I'm not dismissing their concerns. I'm just trying to unravel why patients feel the way that they do. I've noticed that many people believe that the more painful the problem, that there must be something obviously wrong. That's part of the reason why people visit the emergency room. Pain, fainting, fractures. These are the things that typically lead people to seek emergency care. Those conditions are easier to prove in certain instances compared to contusions, muscle tears, which sometimes require further testing. As clinicians, we develop theories about what might have happened, but I understand why that's frustrating from a patient's perspective. If you have disabling pain, but no test confirms it, MRIs, CAT scans, nerve studies, and lab work are the main tools we use to figure things out. Some syndromes have a neuropathic component that we can test with an EMG, but that only identifies certain nerve-related problems, not pain itself. It's just a test of function. I've seen plenty of patients referred for nerve studies, and then they come back essentially normal. So I know how frustrating that must be for them. In the early years of my practice, there was a pressure to just do the test and move on. But I've always felt that that wasn't not the right approach for my personal style of practice. Some colleagues bridged that gap by doing the test on one day and then setting up a separate visit for evaluation, which I think is clinically the right thing to do, even in the challenging current volume-driven healthcare system. I spent a lot of time explaining to this patient that I actually agreed with their surgeon's assessment, but these diagnoses are hard to prove. I also emphasize that physical therapy is often the first step in addressing any of these conditions. I asked if they had gone to therapy as recommended, but they elected not to. Cost was one particular reason, and I understand that for sure. But they also felt that they couldn't trust the physician after their experience. They were frustrated that no specific diagnosis was given, and that contributed to their distrust, even though the surgeon was likely trying to do the right thing. When somebody's already angry, that message can simply just get lost. To cap it off, the patient also did not feel like the surgeon was taking them seriously. In the end, I didn't give them any new information, but I tried to deliver it differently and listen to their frustrations so that they felt heard. I think that's what they needed the most, to feel like someone actually listened to them. The previous physician may have had the best intentions, but the patient didn't feel understood, and that's where I spent most of my time. I gave them some home exercises and stressed that physical therapy can help clarify the diagnosis, but only if they were going to give it a try. If therapy doesn't work, that typically leads to more testing, but at that point, I could tell their frustration was too high to even consider it. This isn't the first time I've had this kind of experience. I think some patients believe diagnoses are simple and that every condition can be detected at any point in time. I often use the analogy of a person looking sick with a normal temperature. Just because their temperature is normal doesn't mean that they aren't sick. I think that people understand this particular analogy, but interestingly, it doesn't seem to translate when it comes to musculoskeletal pain. When I explain to somebody that their pain is not detectable, but they're in a severe amount of disability as a result, it makes it really very hard for them to essentially buy my explanation. There's more nuance, and sometimes a long explanation isn't helpful. Some have the patience to listen to my long, drawn out explanations, and some don't. Over time, I've realized I can't convince every patient with detailed explanations. I'm human and have my limits, but I do my best. I make time to listen to my patients, and I'm accessible through email or text if they want to share ideas or links that they researched. Even if I disagree with something, I don't dismiss it because that can add to the patient's frustration. As a physician, it bothers me when patients feel like they aren't heard. I understand that not all physicians are warm and empathetic, and not all are willing to hold patients' hands going through a difficult diagnosis. Some will say, "It's not that, see you later," and simply move on. That's just really not the way I approach things, and it's not the kind of care I advocate for. But I know that's the reality in our healthcare system. Everybody is different, not just patients, but also physicians. My point is that musculoskeletal diagnoses aren't always simple. Even with all the advances in MRI, CT, and even artificial intelligence, diagnostic tools still have their limitations. I'd ask patients to keep in mind that it's just not always that simple, even with these advances, and sometimes we just simply don't know. To my patient, I explained that while I might not know someone in their area to help them, they should not give up, even though it might feel that way. Ultimately, I think we should all try to be more patient with each other, and that's both patients and physicians. Physicians, please try to be patient with trying to figure out what our patient's condition actually is. Although we know that things aren't obvious, it might take some extra legwork, but please keep in mind that there is someone on the other end who is there because they are in pain. Similarly, I ask that patients also try to give a little bit more leniency to a physician that's trying to help. I would ask you to consider that it's not always that simple to make a diagnosis, no matter how painful it is, and that the physician doesn't always know. Sometimes it's simply that, and not because they are actually being lazy or anything. That being said, on the flip side, to my physicians, I ask that you guys don't be lazy. I don't mean that you guys aren't working hard, because you guys obviously are on a day-to-day basis, but sometimes we come across a diagnosis that we know is difficult to make, and it can bring us a certain amount of headache. We tend not to make these diagnoses, and I'm just going to say it out loud because I've listened to us talk after hours, and over the years, I know how we think, and I know that it's not to say that we're trying to evade arriving at the right diagnosis, but at the same time, I don't think we like to make these diagnoses because they're long conversations, which are never easy. Not every physician wants difficult problems all the time. That's every human, a patient, a physician, we're all human. That's hard to deal with difficult problems all the time. I think it's just easier for us to not see the hard problems and just fix as many simple ones as we can. Again, I'm not here to say that you're a bad physician for doing one or the other. I'm just trying to explain that that's just how it is sometimes. Some people want to work at a certain pace and see a certain amount of people, others don't. Don't be too dismissive because people are looking for help. They're not there to annoy you, they're there to ask you for help. Conversely, patients, please don't project your frustrations on us. Especially some of us are really trying to help. Getting back to my patient, there was a lot of you are all alike or you're all the same kind of a tone. I just have to sit there and listen to it because I know how it feels not to be heard, and I understand that they're frustrated. It's difficult for me to not react to that while they're expressing how they feel. As a physician, that's not really my place to explain how they're making me feel. Again, I don't want to use up their time for that. On the flip side, I don't condone abusiveness on either parts, but I'm just saying that not all physicians are the same, but no one ever really deserves to be abused verbally. The ones that want to help, the ones that have true empathy, we're out there. I guess what I'm saying is I understand your frustration. Not everything is simple. Not everything is detectable. We should all just try our best to be patient with one another. That being said, if you are in pain and you don't have someone that you trust or feel like is advocating for you, please shoot me a message. I don't know if there's someone I know in your area, but again, I am willing to try and help. Thanks again for listening. Take care. Thank you for listening to the Talking Rehab podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.